شكرا جزيلا. بس correction, inhaled antibiotic, not
And
steroid.
sorry, inhaled
Eh,
antibiotics, I
no.
should say. I'm sorry. You know, pulmonologists, they think inhaled steroids more than inhaled antibiotics.
Good
But
answer.
because you carry a lot of hats, that's why.
Okay. So I should talk for 20 minutes. I'll try to stop at 15 minutes.
Thank you.
Where's back and forth?
The green one is fourth.
شوف احنا ما نعرف التكنولوجيا. The green one.
Green takes you forward.
Okay. Salam alaikum. Sabah al khair. Thank you very much for having me. Actually, this session is about asthma, and I was injected in this session by mistake. Okay. But because in asthma, I have to put one asthma slide for you. Okay. So at least you know that. Okay. So the title in the program is Inhaled Antibiotic in Pneumonia. Just for correction, there is no antibiotic for pneumonia, okay? Pneumonia is an outpatient patient, we don't give. This is inhaled antibiotic for ventilator-associated pneumonia, just for correction, or lung infection. That's a better term. One more time. شو أنا ما أعرف. To me, to where? Forward. ما عندي forward دكتور. Green. Subhanallah, إنها لا تعمل أبصار. It's in the middle. So the term inhaled, nebulized, aerolized, in the literature, they use interchangeably. I'm okay. Yes, yes. It used interchangeably in the literature. So whatever term we use as a answer the question why? Because it goes directly to the infected area without a systemic side effect. So it's very simple. It doesn't need a brain actually. And the drug that are used are well known. So let's go back to history. It's a nice review of somebody interested in the literature of the therapeutic aerosols. The first people are the Egyptian actually, and it is they have written that how they use nebulized antibiotic. Even recently in 1940s and 50s, when cigarette came, they said this is good treatment for asthma, and this is a true picture. So cigarette for the relief of asthma. So everybody likes things to go directly to the lung. So you smoke and you get asthma relief. And we know that that was there. This is true picture. This is not a Photoshop, by the way. So this is your asthma talk for today. Let's go to medical history. The interest was initially in Pseudomonas, and gradually it emerged, and everything know about antibiotic. Where we need to deliver the antibiotic deep down in the lung, not in the upper airway. And this is very important message. I'll come at the end of the slides. And these are the anatomy, respiratory bronchioles, alveolar ducts. Yesterday, I enjoyed the lecture by Dr. Amal Al-Amri. She talked about inhaled antibiotic in bronchiectasis, and she mentioned that clearly. So my talk is not about bronchiectasis, just to mention that. So if you know, that was mentioned nicely, clearly. So thanks for review. An important information that this inhaled antibiotic these inhaled antibiotics, you need to make sure the particle size are between 1 to 5 micrometer. Otherwise, it will not work. And this is a very important message. It should have also a low solubility. You don't want systemic absorption. You need them to stay in the lung, to stay on the bug itself. You don't want them to go systemic, and that's the main concept. Now, in the size-wise, whatever inhaled nebulizer, inhaled solution, inhaled powder you use, the proper size should be between 0.5 and 3 micrometer. Larger size, it will stay in the upper airway, is useless. Much smaller size, it will go all the way to alveoli, then come back all the way out. It will not stay. And this is very important. And this is nice review about the mechanism, how each particle from physical point of view, where they go. They have different movement, impaction, sedimentation, and Brownian motion. Cystic fibrosis, this is where you learn from in inhaled antibiotic. I always ask why they use aminoglycoside. And I always say they are used because they are not used. In the real life, we don't use aminoglycoside IV to treat UTI and pneumonia, and because of nephrotoxicity, we have cephalosporin. So because aminoglycosides are not used, they retain their potency. That's why if you have multi-drug resistant, extensive drug resistant, severe drug resistant, even TB, it will work. Because for the last 20 years, nobody using IV aminoglycoside. That is the important message why all the studies as tobramycin, amikacin. plus other factor, and even in ATS guideline. So, for example, the tobramycin, which all of you know, we have the one who started the Toby, the solution, we have the Bramitop, we have the inhaler powder, is all being used extensively in cystic fibrosis. Very good. Non-cystic bronchiectasis, very good. My talk is about in the hospital, in ventilated associated pneumonia. And this is different between each preparation. Some can be given faster and quicker. And it improves overall survival. So we learn these inhaled antibiotics are very good. Over years, these patients do better. Why we should not use them for a severe disease, ventilator-associated pneumonia? It's a drug that we know. And we have aztreonam. And later, aztreonam kicked in, and everybody used aztreonam inhalation. Why? Same concept. Rarely ever somebody used aztreonam in the hospital. For the last 5 years, I used it only yesterday. Somebody had anaphylactic shock to cephalosporin. I have to order it for IV. It retained the potency. So this is the setup. So antibiotic local therapy inhaled was started exclusively for chronic cystic fibrosis infection. It showed great result. Then why not use an acute infection? Acute infection, I mean hospital-acquired ventilator-associated pneumonia, or the patient has tracheostomy and there's a pneumonia. Standard community-acquired pneumonia, there's no rule for it, just for correction. So studies start to be launched, and this is one of the largest trial, inhaled amikacin, in addition to standard of care for mechanically ventilated patients. This is 153 hospital, biggest study actually. They use 400 milligram amikacin, and unfortunately, there is no different outcome. Both used IV antibiotic, one arm used in addition inhaled antibiotic, 255. Then people say, why not use colistin? And again, that was mentioned yesterday. And colistin, same concept. For the last 20 years, colistin, nobody used it until. And there are different preparation of colistin actually, and it depends. So usually the 1 million unit, it's equal 33 milligram. This is what you see on the label. And Stanford, we, the IG doctor, our reference is the Stanford, the small book, okay? This is the dose of inhalation, and like it's again mentioned. So they work, but you need to have one important information. So efficacy of nebulized colistin-based therapy for ventilated associated pneumonia, Aztobacter pneumoniae. In that study, it worked very nicely. These patients did very well. So what I want to tell you now, I'm not going to review the studies. There are studies shows it's very good, study shows not good, study shows sometimes good. And this is a meta-analysis. Overall, in this meta-analysis from 2021, nebulized colistin, the 71% in favor of adding nebulized colistin. But this is mainly they work if you have multi-drug resistant organism, not standard antibiotic. And this is summary of all the antibiotic in cystic fibrosis, non-cystic fibrosis, and the VAP. This is my talk today, is the last part. Gentamicin, chromycin, amikacin, we have colistin, we have vancomycin, we have aztreonam, we have ceftazidime, we have ticarcinin, we have Cipro. And side effect is minimal. And that's a whole concept. You give local therapy. Sometimes get bronchospasm, it's managed. Otherwise, you can say they are safe drug. Over the last 10 years, what are the bacteria that associate with mortality? Staph aureus, bacteria of the lung. Burkholderia, bacteria of the lung. Pseudomonas, bacteria of the lung. Klebsiella, bacteria of the lung. E. coli, bacteria of the lung. Aztobacter baumannii, bacteria of the lung. Mycobacterium, bacteria of the lung, of course, well known. Neisseria is not in the lung, and Streptococcus pyogen. 7 out of 10, the 10 bacteria that kills people, some of them, they go to the lung. We need something to manage our patient, and majority in ICU. So many subsequent studies of nebulized antibiotic in ICU ventilator-associated pneumonia showed controversial result. Why is that? The drug is good. The tobramycin, the Toby, the Bramitop, drug is good. There's no issue with the drug. And you can see all these different meta-analysis from 2009, 2017, 2017. The conclusion says they are good, but not very good. What we are missing? So I have asked a question here. What are the 3 pillars of a nice song? If you have to have a nice song, okay, you need a hit song, okay, a nice good music. There are 3 pillars. Number 1, الأبيات الشعر, الكلمات, the lyric. You need a nice lyric, the words. That's important. So that's the first principle. The words are your antibiotic, inhaled antibiotic, the tubermycin, the colistin, the astrinam. They are very good, no issue with it. Second part, you need the delivery mode, the music, اللحن. You need to know how to deliver this with the instrument. If you use the instrument, somebody is famous using piano, and you give this song to Fairuz, or you give this song to Nancy Ajram, they may not do the same thing. It's different musical instrument. It's not the singer are bad, it's the different instrument. And the last one is the most important part. So in ICU, these are ventilated. The mouth is not completely open. The mouth is partially open. In normal cystic fibrosis, the mouth is open. The whole trachea is open. In ICU, the trachea takes 60%, sorry, the endotracheal tube takes 60% of the trachea. It doesn't go to the lung completely. And you have tracheostomy. There's a lot of secretion inside, okay? So you need to choose your musical instrument. And there are 3 musical instruments: the traditional jet nebulizer, the ultrasonic nebulizer, and the vibrating mesh nebulizer. You need to use the best delivery mode for these excellent antibiotics to reach to the target. This is very important. So if you look to this slide, and that's enough to focus here, right here. So if you use the regular nebulizer, in best scenario, 10% will go to the lung. Most of the time, 2%. So if you do a study, the patient will not do better. If you use the ultrasonic nebulizer, it's 10 to 17%. The vibrating mesh technology, up to 30% in good hand. If you use that technology and not in good hand, it's around 13, which is 10%, which will not work. So my message to you here, if you want to use a nebulized antibiotic, which are all good, there's no issue about the product itself. You have to know what's the delivery mode, what's the musical instrument you're using to deliver this antibiotic. And the best one is the vibrating mesh nebulizer. Why? Because these mesh, once it's projected to energy, it vibrates and produce 120,000 per second vibration. So it vibrates a lot. So the particles goes to the size that we want to deliver to the airway. Not the big size, not the small size, the middle size. And this one study, if you use vibrating mesh nebulizer, 85% of the product goes to the lung with a special CT scan technology and isotope technology, while you use a jet nebulizer, only 50%. And this is how they will work. This is the way they work. And you reach the particle size that you want to reach to your lung. This is very, very important. So what makes a good music? The medicine. It's a very good drug. All of them. We are not creating new drug. We are not creating new drug. It's not like a new disease that you're creating new monoclonal antibodies. It's a well-known drug. It's an old drug. 2, the delivery mode. Use your best musical instrument. Okay? The third one is the pulmonologist or the intensivist or the respiratory therapist. Is the singer. You're the operator there. Buying an important, expensive product, but you don't know how to operate, it's like you bring a nice song, a nice lyric, and you give to a singer who doesn't know how to sing. So this takes me to the last part of my talk today, is the effect of inspiratory maneuvers. Who do the inspiratory maneuvers? You, as a doctor, respiratory therapist, the pulmonologist. You need to know where to put that instrument, okay? Many hospitals, not many, I think 70%, in UAE, they don't have respiratory therapists, right or wrong? Right or wrong? Nobody's answering. Right, of course, right. You give to the nurse, they don't know where to put it. You have to make sure that operator use the HME because it will go there, it will block there. And that's why I heard many doctors saying, doctor, we used it, didn't work. And I asked them, where you put your drug? They don't know. We just put it there, like a regular nebulizer. So Yesterday in this conference, I saw my friend. They are the respiratory therapist back in Sheikh Shahbut Medical City. I took a picture with them. You need to have a good person who deliver the drug to the patient. Buying an expensive drug, buying an expensive instrument, but the end, the one who's singing, he doesn't know how to sing, it will not work. So quiz, what fails a good poem or lyric and a good music? A bad person. The bad person is us, it's me. I am the doctor who's operating the ventilator, the respiratory therapist, the pulmonologist. So I buy a good drug. So that's the important message. So what makes my last few slides? What makes a good music? The medicine. You have a good drug, no issues. How to deliver? I showed you there are three main technology. You buy whatever technology commercial you need. I'm not promoting a specific one, but the jet nebulizer are the best one. And a bad operator. It will not work. That answered the question. Why many studies showed it's beneficial? Why many studies showed it's not beneficial? Because use the right drug, but they did bad in item 2 and 3. Why? If you use the good drug, the medicine will land in the wrong area. Like this guy, he wants to parachute jump and he's landing in the lake and the crocodile are waiting for him. So you have to make sure that your drug lands in the correct area, doesn't land in the upper airway, and the size are not very small, that because it will go down, it will come out again. So inhaled antibiotic is also used to prevent ventilator. So all what I mentioned overview of treatment. Now there's ongoing studies. What about prevention? There's a terminology that we keep changing. Ventilator-associated tracheitis, ventilator-associated bronchitis, or somebody has a trach and there's a pseudomonas there and CRP slightly high. Shall I treat, not treat? So there's also say, let's try that and treat locally. Let's deliver the antibiotic locally in the upper airway so we kill the bacteria in the upper airway. It will not go down. We don't know the answer yet. So these are different ways that you can prevent nosocomial pneumonia, including antibiotic. And still we don't know. Okay, so in the past, I mentioned about the treatment and also this ongoing information. Guidelines, we like guidelines. Very good. So this is a European respiratory guideline in management of hospital acquired. They did not comment anything on nebulized antibiotic. Okay, and also this is European Society of Infectious Disease, and what they say, we suggest avoiding routine use of nebulized antibiotic. Routine use. They didn't say don't use. Okay, here as a standard clinical practice. So the European, they say, we don't know yet. Maybe their study didn't show, so they are not recommending. So the European respiratory, they kept quiet, they kept silent. They didn't say use it, they didn't say don't use it. The European infectious disease, they said don't use it routinely as a standard of care. Okay? Although the review and meta-analysis 2019 favor adding nebulized antibiotic. You can see on the right side. There's a group of investigators, they are European Investigator Network for Nebulized Antibiotic. This is published 2020 after the guideline. So the same people who put the guideline, but they put an update 2020 because the guideline is still there, it's not new. What they recommended, if you want to use, we tell you please use, but use properly, exactly. And you can see what delivery mode, musical instrument they advise to take. And again, it gives you that. Let's go to USA, the Infectious Disease Society of America, then American Thoracic Society, they have different views. They say here, the question, should patient with VAP due to gram-negative bacilli be treated with combination of inhaled and systemic antibiotic or systemic antibiotic alone? And the answer is, it is reasonable to consider adjunctive inhaled antibiotic therapy for these patients. These patients in ICU, they have multi-drug resistant. They're going to die. They have no other options. So they said, yes, if you have these organisms, either confirmed or highly suspected, if you go to any ICUs, these are the bugs that they carry, then it is useful to use an adjuvant inhaled antibiotic therapy. What we have in the future, we have a phage therapy is coming for the pulmonary infection, which is a virus. You inject, it goes inside the lung. and eat the bacteria. That's why the name phage therapy. You studied about phage therapy, so it kills the bacteria. We have the nanotechnology, which I don't understand what is it. I'm a old person. I think this is Dr. Bassam Mahmoud area, artificial intelligence and technology. I don't know anything. So the nanotechnology is coming to improve the delivery of antibiotic to the lung. Okay, it's a nano for the infection, of course. There also we have inhaled antifungal, and we have also inhaled antivirus. So I was the director of the Corona Field Hospital in Ajman for 1 year. Now we have no much. So we use extensively the remdesivir. Now there's ongoing studies to inhaled remdesivir. Final 2 slides. So in bronchiectasis is good, cystic fibrosis is good, intubated patient, we need to know that. This is the most recent. We need to improve the publication. So take home message, inhaled antibiotic are excellent for CF bronchiectasis. Inhaled antibiotic are very good for non-CF bronchiectasis. The available inhaled antibiotic are good. So I give you excellent and very good and good for that, but you need to use.
It's not me.
You need to use the proper device. You need to use the proper technique. And still we need to more, yes, use it as an adjuvant therapy for difficult to treat, mainly gram-negative infection. And thank you very much.
Thank you very much, Dr. Hussein. That was very interesting and beautiful talk. Thank you very much for
Shukran.
this. We have comments and questions, Dr. Hussein.